Hello, I am Dr. N.S. Mani. Today in this session, number 4 of cardiology, which is a continuation of the postgraduate medical entrance test practice session, I am going to tell you a few clinical conditions which can be used in the MCQ format. I already uploaded 3 similar videos in the last 2 days, and I started this academic year of 2012-13 on February 29th. The previous academic year, more than 61 videos have been uploaded, including sessions on concept bridge, which will help you to answer the entrance test as well as in the clinical examination. Please visit my site www.youtube.com/acepgmet, and you can subscribe so that you will get the upload link every day as and when it happens. Also, you can log on to www.facebook.com/acepgmet and invite as friend, and you will get the links posted in the Facebook as well. So please visit the channel for concept bridge, clinical cases, discussions, and postgraduate entrance test oriented classes. Already 11 or 12 question paper sessions have been uploaded, which you can go through. In those videos, there is no audio because the purpose is to read the question and answer them just as if you do in the examination. So they are actually practice sessions, but better videos will be uploaded from this session onwards. So we shall start the discussion. The following cutaneous stigmata may be associated with congenital heart disease. State which are true and which are false. Steinberg sign, hypotelorism, absent radius, distal triradius, and low hairline. So state which are false and which are true. Please write down and then only go forward. You can use the freeze button to stop the video now, and then use the play button once you answer the question completely. Okay, that's answer. All are true. Steinberg sign, hypotelorism, absent radius, distal triradius, and low hairline are the cutaneous stigmata which can be associated with congenital heart disease. You may be very well knowing that neurocutaneous markers are very well known to help you in diagnosis, because the nervous tissue and the cutaneous tissue develop from the same embryonal tissue, that is ectoderm. But here the explanation is a little different. Steinberg sign is where the thumb, when held in clenched hand, protrudes beyond the palm. This is characteristic of Marfan syndrome and suggests arachnodactyly. And in Marfan syndrome, the elastic tissues are so soft and long that in the case of aorta, the root dilatation can occur. Hypotelorism is found in Patau syndrome, which is associated with number of cardiac defects, including VSD, ASD, PDA, coarctation, and bicuspid, aortic and pulmonary valve. What is that? Patau syndrome is one of the trisomies. You know, there are 3 trisomies mainly clinically important. Most common is the Down syndrome, then the Edwards syndrome, which is trisomy 18, and Patau syndrome is trisomy 13. Other trisomies are there, but most of them are lethal. TAR syndrome, what is TAR? TAR syndrome, thrombocytopenia and absent radius, is associated with ASD and Fallot Tetralogy. Then a distal triradius is found in Down syndrome, which is associated with the atrioventricular septal defect. And a low hairline in Turner syndrome, which is associated with coarctation of aorta. Turner syndrome is characterized by XO, that is, there is only one X and the other X is missing. Female, short stature with left-sided congenital heart disease, Noonan syndrome is a similar situation where the dysmorphology is almost the same. Most of the Noonan syndrome are male children. Turner syndrome are female genitalia. And in the case of Noonan, the genetic disorder is different. It's an autosomal disorder, and it's most often associated with the right heart disease like pulmonary stenosis. Now, in the fetal circulation, there is a second question. State which one is true and which one is false. In the case of All India entrance and Kerala entrance and state other board entrances, such true and false statement may not be there as multiple answers but single. So all these questions can be slightly modified to make one true or one false. So that what I mean to say is that by explaining one question, 5 types of questions may be answered by the student. So listen to the explanation also as well. So in this fetal circulation, which is true and false, approximately each volume of blood are pumped by the left and right ventricle inside the fetus, which means in the intrauterine life. Is it true or false? Then saturation of blood returned from placenta is about 80%. Then approximately 25% of the cardiac output traverses the fetal lung. Then the ductus venosus is probe patent in 75% of the cases. Then pulmonary vascular resistance is suprasystemic. So this question is mainly concentrating on your understanding of the hemodynamics of fetal circulation. So freeze the video, answer the question completely, and then play the button. The approximately each volume of blood are pumped by left and right ventricle is true fact. The saturation of blood returning from placenta is about 80%. That's also a true fact. Pulmonary vascular resistance is above the systemic resistance. The systemic resistance is low because of the AV fistula-like situation in the umbilical artery and vein inside the placenta. But the other two statements are false. That is, 25% cardiac output traverses the fetal lung. That's not. Most of the no, we will discuss later. The ductus venosus is probe patent in 70% of the cases. So in the fetal circulation, vast majority of the blood bypasses the lung through the ductus arteriosus, but the right and left ventricles pump approximately equal volume, because that has to be true. Which one? That is, right and left ventricle have to pump equal volume. The fetus is relatively hypoxemic, with the fetal hemoglobin being used to increase oxygen carriage to the tissues. It is the HbF which is there, which has got high binding capacity to the oxygen at low PO2. Only 10% of the cardiac output traverses the fetal lung, and the ductus venosus remains patent until the postnatal period. It doesn't close in the fetal life. Actually, closure of ductus venosus, closure of ductus arteriosus, closure of the foramen ovale, then cutting of the umbilical vessels, and decrease in the resistance of the pulmonary system, increase in the blood pressure in the systemic system. These are the main changes which occur in the natal life after delivery. Approximately 50% umbilical venous catheter can be passed through into the right atrium postnatally. The pulmonary vascular resistance remains suprasystemic until the time of the first breath, and the combination of lung aeration reducing pulmonary blood pressure and umbilical ligation increasing systemic blood pressure reverses the situation. Now the third question is about nitric oxide or endothelial relaxation factor. State which one is true or false. Probably you have learned this in the biochemistry as well, and also in physiology and pathology. Unlike prostacyclin, promotes platelet aggregation, then can be enzymatically synthesized from glyceryl trinitrate, then has a half-life of 1 to 2 minutes in vivo, then can be synthesized by macrophages, and then is synthesized from L-arginine. So regarding nitric oxide, which statements are true and which are false? So there are 3 statements which are true. That is, nitric oxide can be enzymatically synthesized from glyceryl trinitrate. Nitric oxide can be synthesized by macrophages, and it is also synthesized from the L-arginine. The substrate is L-arginine. Now the false statements are, unlike prostacyclin, nitric oxide promotes platelet aggregation, and half-life of nitric oxide is 1 to 2 minutes in vivo. Let us see what is the true fact there. Explanation. The prostaglandin I2 inhibits platelet aggregation via cyclic AMP, while nitric oxide works via GMP. So they inhibit rather than facilitate. Glycerol, trinitrate and nitroprusside are converted to nitric oxide before having their pharmacological effects. Nitric oxide is synthesized by macrophages, lymphocyte, endothelial cells, and is a neurotransmitter and vasodilator. When given by inhalation, it is a specific pulmonary vasodilator because of its short half-life. So there is a proposal, or rather study, to use it in the treatment of primary pulmonary hypertension. Sildenafil is one drug which can do this wonder. Prostacyclin, or PGI2, is a member of the family of lipid molecules known as eicosanoids. During the 1960s, a UK research team headed by Professor John Vane began to explore the role of prostaglandins in anaphylaxis and respiratory disease. Working with a team for the Royal College of Surgeons, Sir John discovered that aspirin and other oral anti-inflammatory drugs work by inhibiting the synthesis of prostaglandins. Prostacyclin is produced in endothelial cells from prostaglandin H2 or PGH2 by the action of the enzyme prostacyclin synthase. Although prostacyclin is considered an independent mediator, it is called PGI2 or prostaglandin I2 in eicosanoid nomenclature and is a member of the prostanoid together with prostaglandins and thromboxane. The series 3 prostaglandin PGH3 also follows the prostacyclin synthase pathway, yielding another prostacyclin called PGI3. The unqualified term prostacyclin usually refers to PGI2. PGI2 is derived from arachidonic acid. PGI3 is derived from EPA. I am showing the pathway of production of PGI2. Arachidonic acid is produced from diacylglycerol or phospholipid, and PGH2 synthase, that is COX1 and COX2 and peroxidase, convert into prostaglandin H2. PGD synthase makes it PG2. PGE synthase makes it PGE2 and F2. Then prostacyclin synthase makes it prostacyclin PGI2, and in the endothelium it becomes 6-keto PGF1 alpha. Then thromboxane synthase converts PGH2 to thromboxane TXA2, and then in the platelets it converts to thromboxane TXA2. The arachidonic acid can also be converted by lipoxygenase FLAP and alox5 to HPETE, that is hydroperoxytetranoic acid. Then becomes the leukotriene, which with the glutathione, it can become the glutathione S transferase enzyme facilitates to become leukotriene C4. Then glutamic acid is released, then leukotriene D4, then leukotriene pathway. These are important in asthma. Leukotriene with water becomes LTB4. This is the eicosanoid synthesis, or prostacyclin is shown near the bottom center. Mode of action is classical functions of prostacyclin are vessel tone, anti-proliferative and anti-thrombotic.